Pharmacon means drug and logos means to study. So pharmacology basically deals with to study all about the drugs. It encompasses three things. One, about the drug. Number two, what the drug is doing to the body. And number three, what the body is doing to the drug. Okay. When we study pharmacology about any drug, we deal with two important aspects of the drug. One is pharmacokinetics and one is pharmacodynamics. So what we will be starting from today will be about pharmacokinetics. What do we mean by pharmacokinetics? Basically it deals with what the body is doing to the drug. It encompasses four important aspects. Number one is absorption, number two distribution, number three metabolism or biotransformation, and number four is elimination. What do we mean by absorption? Absorption means basically when the drug is taken in by any route to reach to the circulation, systemic circulation, the whole process is said to be absorption. And when the drug has reached to the systemic circulation, that has to be distributed to different tissues for action and other effects. That is called distribution. After distribution, the drug has to be metabolized so that it can be easily eliminated from the body. Primary site of metabolism is liver. So this part basically the conversion of the compound or the drug to a complex or to a molecule that is easily eliminated, that is metabolism or biotransformation, and finally the drug is eliminated from the body, called elimination. So today's topic we will be discussing on pharmacokinetics, particularly on absorption and distribution. So what is pharmacokinetics? It's the quantitative study of drug movement in, through and out of the body. All pharmacokinetic process means absorption, distribution, elimination, metabolism and elimination, they involve transport of the drug across the biological membrane. We know about the biological membrane containing bilipid layer. So all drugs basically when taken in, they undergo absorption, distribution, metabolism and elimination, particularly involving transport across the biological membranes, otherwise it is not possible. So in the schematic diagram, you see the drug dosage is taken in and the drug is reaching to the systemic circulation, come under absorption. Then from the systemic circulation, the drug is taken in different tissues called distribution, and finally the drug is metabolized and then eliminated from the body via urine, bile, feces, sweat and saliva. These are the different routes of elimination of the body, of the drug from the body. So before going to absorption and distribution and other pharmacokinetic process, we should all know about the transport of drug across the biological membrane, so that the study of the different aspects of pharmacokinetics will be easier. Now this from the physiology class is basically a cell membrane having a bilipid layer. The outer layer is lipophilic, is basically hydrophilic, and the inner layers are lipophilic or hydrophobic. Now there are also intrinsic, extrinsic and the transmembrane proteins. Transmembrane proteins are making having a pore for the easy passage of ions and other substances. Now membrane transport mechanism in drug absorption, it can occur via two broad headings. One is passive diffusion and filtration, that involve either passive diffusion or filtration, and there are specialized transport across the biological membrane called carrier-mediated, also transporters and pinocytosis. So coming to the passive diffusion. Passive diffusion basically here the drug is transported across the membrane basically along the electrochemical gradient or concentration gradient. So it is transported from higher concentration to lower concentration. No energy is needed for this type of transport. So, drug diffuses drug diffuses across the membrane in the direction of its concentration gradient, the membrane playing no active role in the process. Now, what are the factors that govern the passive diffusion? Number one is lipid solubility. Lipid solubility, basically greater the lipid soluble drug, more it will be readily passing across the cell membrane or biological membrane. So, lipid solubility, that is measured by lipid water partition coefficient of drug. So, more the lipid water partition coefficient of drug, more is the drug lipid soluble, and more it can readily cross the plasma membrane. pH of the drug, we will be coming in details about that a little later. And the concentration gradient, the higher the concentration gradient, the more readily the drug will cross. Now, coming to the influence of pH on the transport of drug across the biological membrane. Most of the drugs that we take that are weak electrolytes, either they are weaker acidic drugs, most of the drugs, or they are weaker basic drugs. Okay. Now, their ionization, now when they are weaker acid or weaker basic drugs, so partly they are ionized, partly they are non-ionized. So, their ionization is dependent on the pH of the medium. Okay, that is governed by the equation pH equal to pKa plus log of A minus, that is anion, by HA, that is unionized form. This equation is for the weakly acidic drugs. Okay. For the weakly basic drugs, the equation will be this. Okay. pH equal to pKa plus log of HB, that is the unionized form of the weakly basic drugs, by B plus, that is the ionized form. उल्टो हो जाए, ठीक है. Now, what the pKa here? pKa basically is a constant, and what is the value of it? See, if the concentration of the ionized and the unionized form, they are equal, then what will happen? Log A minus by HA will become 1, right? And log 1 is equal to 0. So, pH equal to pKa. That means pKa is the value of pH, numerical value of pH, at which pH the ionized and the unionized forms are equal, or the drug is 50% ionized. Okay. একটা drug যে pH এ 50% ionized থাকবে, 50% unionized, the value of that pH is basically pKa. Okay. It is similar to that in case of weakly basic drugs also. Now, weakly acidic drugs, example aspirin, very commonly used drug. Aspirin basically used as an analgesic and an anti-inflammatory drug, and also other purposes are there. So, aspirin has got a pKa value of 3.5 average. So, it is a weakly acidic drugs which form salt with cations. If it is a weakly acidic drug, some ionized form will be there, anion will be there, that will form salt with the cations. They ionize more at the alkaline medium. কিভাবে হবে? যদি এই জিনিসটা বেসিক্যালি if the drug is more if the basically medium is more alkaline, that means the pH will go higher, right? pH will go higher, that means pH minus pKa will be positive value, that means A minus will be more than HA. Am I clear? বোঝা গেছে রে? A weakly acidic drug, if in a basic medium, what will happen? The pH will be more. যতটা মিডিয়ামটা বেসিক হবে ততটা pH টা বাড়বে. What the physiological pH? Around 7, right? As the pK value is 3.5, it is a weakly acidic drugs, less than 7. So as the pH of the medium will increase, or as the medium will be more alkaline, that means the log of A minus by HA will be positive, more positive. যতটা বাড়বে ততটা পজিটিভ হবে. তার মানে ionized part of drug, or the ionized part of drug will be more than the unionized form. So that is said only that the weakly acidic drugs ionize more at alkaline pH. It again, the converse is true for the weakly basic drugs. Weakly basic drugs are more ionized at acidic medium and unionized more at basic medium. Similar for weakly acidic drugs. And one scale change in pH causes 10-fold change in ionization, that you can see with the mathematical form. So similarly for weakly basic drugs, example atropine, very common drug. So atropine with a pKa of 7, which forms salt with anions, conversely ionized more at acidic pH. এটুকু বোঝা গেছে, very important concept. Weakly acidic drugs are more ionized at basic alkaline medium, and weakly basic drugs are more ionized at acidic medium. Now implications, এটা জানলে লাভ কি আছে? Number 1, acidic drugs are absorbed more from the stomach, while basic drugs are absorbed more from the intestine. Why? বলো যদি বলো. More ionized, less will be absorbed from the membrane, so less absorption. Acidic drugs at acidic medium, more unionized, so it can easily cross the membrane and can easily be absorbed. So acidic drugs are absorbed from the stomach, while basic drugs are absorbed only when there is an intestine, where the medium is alkaline. Number 2, ion trapping, very important concept. Ion trapping may contribute to gastric mucosal cell damage caused by aspirin. What do you mean by ion trapping? Basically weak electrolytes যে মিডিয়ামে আছে, যেখানে মোর আনআয়োনাইজড ফর্মে আছে. Now it crosses the membrane where the pH is completely different. So what will happen? It will become more ionized within the cell, and now it can pass very slowly across the other side of the membrane. So what will happen? The ions will get trapped. It happens in case of aspirin. Aspirin is a weakly acidic drugs. What happens? We are taking the drug is going into the stomach, medium is acidic, it is more unionized, it passes through the biological membrane, enters the gastric parietal cell, where the medium is more alkaline. Now the drug is more ionized there. Now it cannot cross the other side of the membrane to go to the interstitium, and what will happen? Ion trapping will occur. That is responsible for the gastric mucosal toxicity caused by aspirin. Okay. Number 3, basic drugs attain higher concentration intracellularly because the medium is more alkaline. Basic drugs will be more ionized, and hence acidic drugs are excreted faster in alkaline urine. Very important. In alkaline urine, acidic drugs will be more ionized and cannot be easily reuptaken by the tubules. So acidic drugs are more excreted in the alkaline urine, while the basic drugs are more excreted in the acidic urine, and this fundamental is utilized in poisoning. In the poisoning of or the overdoses of weakly acidic drugs, if the urine is made alkaline, then the drug can be eliminated faster. Like in case of aspirin overdose, we alkalinize the urine. Lipid soluble non-electrolytes like ethanol, they cross readily biological membranes and their transport is pH independent. Now, this was all about the passive diffusion. Passive diffusion which readily crosses the membrane along the concentration gradient without using any energy. Now, coming to the filtration. Filtration is the passage of drug. আমরা পড়েছিলাম কি ট্রান্সমেমব্রেন প্রোটিন আছে যেগুলো অ্যাকুয়াস পোরকে ফর্ম করে. So, filtration is the passage of drug through the aqueous pore in the membrane or through the paracellular space. In between the cells, there can be some gap called paracellular space. So, drugs can pass through those paracellular space governed by hydrostatic or osmotic pressure gradient. So, filtration is basically passage of drug across the biological membrane either through the aqueous pore or through the paracellular space. Lipid insoluble drugs, now lipid soluble drugs they can easily pass across the membrane by passive diffusion. What about the lipid insoluble drugs? They can pass via filtration provided the molecular size of the drug is smaller than the pore, only then it can pass. Diffusion of drugs across capillaries. Capillaries they have got very large paracellular space, particularly except in case of brain which have got tight intercellular junction. So, diffusion of drugs across the capillaries having large paracellular space is dependent on the rate of blood flow because all of the drug can easily pass through it. So, যতটা blood flow টা থাকবে ততটা তাড়াতাড়ি কিন্তু ড্রাগটা ডিফিউজ হবে. So, diffusion of drugs across capillaries having large paracellular space is dependent on rate of blood flow through them rather than on the lipid solubility or the pH of the medium. Now, this is about the passive diffusion. Here in passive diffusion, these are two basically drugs or solutes. One is the red colored which is higher in concentration and one is the basically rhomboid shape. Now, the red colored one is passing across the membrane from higher to lower concentration, that is passive diffusion, and the rhomboid shaped solute basically passing via the aqueous pore, that is filtration. বুঝাতে পেরেছি? রাইট? তো এখন কোন কোন মোড অফ ট্রান্সপোর্টটা শিখলাম আমরা বায়োলজিক্যাল মেমব্রেনে? হ্যাঁ, উপরে কে বলবে? What are the methods of transport of drug across the biological membrane? So, one is passive diffusion, filtration, what we dealt it now, and the others are specialized transport. তার মধ্যে কি আছে? হ্যাঁ, carrier mediated or transporter mediated, and number 2 is pinocytosis. What do you mean by facilitated diffusion? Passive transport. Passive diffusion মানে? বলো, বল রে, বল, শুনতে হবে তো রে। হ্যাঁ, কি? Along the concentration gradient, across the membrane, no energy needed, right? What do you mean filtration? পিছন দিয়ে বল, filtration মানে কি? হ্যাঁ, না, এখানে অ্যাকুয়াস পোর দিয়ে যাবে, দরজা খোলা আছে, অ্যাকুয়াস পোর ওখান দিয়ে যাবে লিপিড ইনসলিবল ড্রাগস। আর কোথায় দিয়ে যাবে? প্যারাসেলুলার স্পেস দিয়ে যাবে। Now coming to the specialized transport, carrier transport. Now many transmembrane proteins are there. What they are used for? They are basically transporting the drugs across the membrane. Okay, Which drugs? Lipid insoluble drugs which cannot diffuse along the membrane. So, a host of transmembrane proteins transport physiologically important ions, nutrients, metabolites, transmitters. Certain transporters also translocate xenobiotics including drugs. Okay. These are what the important features of these carrier transporters. Basically they are specific for the substrate. মানে কিছু কিছু গ্লুকোজ ট্রান্সপোর্টার আছে, GLUT, GLUT, glucose transporter, they transport only the glucose, right? And or the type of substrate, for example there are organic anion transporters, OATP, so they transport organic anions. So it's not specific, it's the type of substrate they are carrying. So specific for the substrate or the type of substrate, they are saturable. The transporters are fixed in number. So as the concentration of the drug or the drug is increased, the transporters get saturated. Okay. So it's saturable, competitively inhibited by analogues. For example, the transporter is carrying 2 or more substrates. Now as the concentration of other substrate is increased, the first substrate cannot be transported. So it can be competitively inhibited by analogues and is much slower than flux through the channels. Ion channels যেগুলো থাকে তাদেরতে কিন্তু slower কাজ করে এটা. So what is the difference between the ion channels and the transporters? Ion channels specifically transport ions for a finite time till the channel is open. Transporters, they combine transiently with the substrate. It can be ion, it can be organic compounds. They transiently combine with the substrate. There is conformational change in the transporters and then they release the substrate and again returns back to the normal form. So how the transporters is working? Transporters, they are combining with the substrate. There is conformational change in the transporter. The substrate is released on the other side and the transporter returns to the normal form. That the way the transporter is working. And how the ion channel is working? There is a basically pore through which the ion passes till the channel is open. When it closes, it cannot pass. So mechanism of action is different for the two. Types of carrier transport, it can be facilitated diffusion or it can be active transport. Active transport can again be basically primary active transport and secondary active transport. What do we mean by facilitated diffusion? These are the class of solute carrier transporters. Basically এখানেও সেলটা ড্রাগটা readily diffuse হয় with the help of the transporter along the concentration gradient. ওখানে in case of passive diffusion there was no help of transporters required because they were lipid soluble drugs. Now these are lipid insoluble drugs, so they take the help of transporter, they move from the higher concentration to the lower concentration. So along the electrochemical gradient they are moving, so no energy is required here. So the transporter belongs to the superfamily class of solute carrier transporters. They operate passively without needing energy and translocate the substrate in the direction along its electrochemical gradient, that is higher concentration to the lower concentration. What is the active transport? Now active transport means they require energy and they are moving the substrate or the drug against the gradient. Okay. So it requires energy inhibited by metabolic poison. They transport the solute against the electrochemical gradient, that is high to low, resulting in selective accumulation of the drug on one side of the membrane. একটা সাইডে লো কনসেন্ট্রেশন আছে, একটা সাইডে হাই কনসেন্ট্রেশন আছে। যদি লো থেকে আরো হাই থেকে নিয়ে যাই তো there will be selective accumulation of drug along one side of the membrane. It can be primary, the active transport can be primary, can be secondary. We are coming to it now. So basically here this is a transporter, the drug is carrying from the transporter is carrying the drug from higher concentration to lower concentration. So is basically facilitated diffusion, and this one basically this is a transporter, it is carrying the drug from the lower concentration to the higher concentration. So, it is the active transport of the drug. Coming to active transport, basically here the energy is required to move the drug from the lower to higher concentration. So, ATP hydrolysis is needed to get the energy. So, energy is obtained directly by the hydrolysis of ATP. In the primary active transport, the transporter at the membrane side or intracellular side, they have got ATP binding cassette. They have got basically ATPase activity that hydrolyze the ATP. So, energy is obtained directly by the hydrolysis of ATP. They belong to the superfamily of ATP binding cassette whose intracellular loops have got ATPase activity. They hydrolyze the ATP so that the movement of the drug can be facilitated. Okay. They mediate only efflux of the solute from the cytoplasm, either to extracellular fluid or to the intracellular organelle like endoplasmic reticulum. Secondary active transport. Now, secondary active transport, here only one solute was being transported from lower concentration to higher concentration in primary active transport. Now, in secondary active transport, there are movement of the two solutes. One is along the electrochemical gradient and the other is against the electrochemical gradient. Energy which is required for the transport of drug against the electrochemical gradient basically is obtained from the movement of the solute from along against the electrochemical gradient. Mane, in this type of active transport affected by another set of solute carrier transporters, the energy to pump one solute is derived from the downhill movement of another solute, which is mostly sodium. Okay, there are sodium glucose transporters. So, secondary active transport, it can be Symport or co-transport, it can be Antiport or exchange transport. In Symport, the two solids move in the same direction. In the Antiport, the two solids move in the opposite direction. So, basically in this, basically there are two substrates A and B, and is the transporter basically in the membrane basically. So, here the drug is, this drug is moving in from lower concentration to the higher concentration using the energy, and that facilitates the movement of substrate B from the lower to the higher concentration. They are moving in the same direction. So, it is basically Symport or co-transport. Antiport, you see substrate A is moving from this to this place while substrate B is moving from this to this place. The movement is in the opposite direction, that is Antiport. Now, properties of carrier transport, as said, it is saturable. Number 2, the maximal rate of transport is dependent on the density of the transporters and in a particular membrane. Genetic polymorphism can alter the density of transporters and affinity of the transporter. And number 4 is tissue specific drug distribution. Certain transporters are more present in certain tissues, and there the drug is more deposited in certain tissues. So, they basically tissue specific drug distribution can occur due to the presence of specific transporters in certain tissues. Now, pinocytosis, here the drug is transported via formation of vesicles. So, it is the process of transport across the cell in particulate form by formation of vesicles. This is applicable to proteins and other big molecules and contribute little to the transport of most of the drug. Now, coming to the first basically pharmacokinetic process, that is absorption. What do we mean by absorption? As said earlier, is the movement of the drug from its site of administration into the systemic circulation, that is absorption. Factors affecting absorption, number 1, transport of drugs across the biological membrane. It's very important. So, depend on the lipid solubility and others. Number 2 is aqueous solubility. Number 3, concentration. Higher the concentration, more will be absorbed. Area of absorbing surface. More the absorbing surface is there, more will be absorption. Vascularity of the absorbing surface. More the area is vascular, more will be absorption. And route of administration. একটা oral থেকে যা absorption হবে intravenous থেকে কিন্তু 100% absorption হয়. So route of absorption differs the rate of absorption. Route of administration basically changes the absorption. Now what are the routes of administration? It can be oral, it can be subcutaneous, skin এর নিচে দিতে হয়, it can be intramuscular, muscle এ দিতে হয়, it can be intravenous and it can be topically vein. ঠিক আছে, এটা পরে আবার নেওয়া হবে ক্লাসটা route of administration এ. Oral route. The limiting factor basically in absorption, the most limiting factor in absorption via the oral route is the epithelial lining of the gastrointestinal tract, which is lipoidal and allows absorption of the lipid soluble drugs. Now, non-ionized lipid soluble drugs like ethanol, it can be readily absorbed from the gastrointestinal tract, and lipid soluble drugs are absorbed more depending on the lipid water partition coefficient, because higher the value, more is the drug lipid soluble. Acidic drugs mane they will be more in the stomach, they will be more unionized. So acidic drugs like salicylates or aspirin, barbiturate, they are predominantly unionized in the acidic medium of stomach and are absorbed from the stomach, while the basic drugs like morphine, they are largely ionized in the stomach and they are absorbed only on reaching the duodenum and intestine. Now, even for the acidic drugs, the problem is stomach mucus layer is thick. So, even for the acidic drug, absorption from the stomach is slower because the mucosa is thick, covered with mucus and the surface area is small. Intestine এ যতটা surface area তার থেকে stomach এর surface area কিন্তু অনেকটাই কম আছে. Absorbing surface area is much larger in the small intestine due to villi. Thus, faster gastric emptying increases the absorption. যতটা gastric emptying faster হবে ততটা ড্রাগটা তাড়াতাড়ি intestine reach করবে, ততটা তাড়াতাড়ি absorb হবে. So, faster gastric emptying accelerates the drug absorption. Now, drug absorption also depend on the particle size. The lower the particle size, the lesser the time is taken for dissolution of drug in the aqueous medium, and lesser will be the time for absorption. So, particle size of the drug in solid dosage form governs the rate of dissolution and in turn the rate of absorption. একটা ড্রাগে তোর বেসিক্যালি absorption দেখতে গেলে from the oral route, there are two factors. One is dissolution time and one is disintegration time. একটা পার্টিকেল সাইজে আছে, ওটাকে disintegrate হতে হবে to different particles and that has to be dissolved in the aqueous medium, then only the absorption will occur. Presence of food. When we are taking the drug after taking meal, so the food is there in the stomach, so what will happen? As the food is there in the stomach, the gastric emptying time will be slower, so drug absorption will be slower. Presence of food dilutes the drug and retards absorption. Moreover, food delays gastric emptying. Highly ionized drugs like gentamicin, like neostigmine, they are poorly absorbed from the GI tract and they are not taken orally. That's why certain drugs are degraded in the gastrointestinal tract, like insulin. Why insulin is only present in the injectable form? Because insulin is degraded in the gastrointestinal tract by basically peptidase. Similarly, penicillin is also degraded in the gastrointestinal tract. So, they are taken in the injectable form. They are ineffective orally. Enteric coated tablet. What do we mean by enteric coated tablet? The tablets here are coated with a coating that basically basically certain drugs they are they get certain drugs in the acidic pH of the stomach, they are destroyed. So they basically they are destroyed. So to avoid the to facilitate the reaching of the drug in the intestine, the drugs are enterically coated so that they cannot be attacked by the acidic pH of the stomach. Like proton pump inhibitors, they are basically enteric coated generally. So enteric coated tablets and sustained release tablets, certain drugs are needed for prolonged action, and basically there a coating is made, so which are basically slowly released, so the drug will be longer acting. So enteric coated tablets and sustained release tablets can be used to overcome acid lability, gastric irritancy and brief duration of action. Oral absorption of certain drug is low, like digoxin and cyclosporine, because certain drugs which are absorbed are extruded back in the gastrointestinal tract by transporters, PGP, P-glycoprotein. These are efflux transporters. Absorption of a drug, these are basically primary active transporter. Absorption of drug can be affected by other concurrently taken drug. দুটো ড্রাগ একসঙ্গে নেওয়া হয়েছে, লাইক টেট্রাসাইক্লিন অ্যান্ড দি calcium. So tetracycline form a complex with the calcium which is non-absorbable. So absorption of a drug can be affected by other concurrently ingested drugs. Alteration of gut flora, like we take antimicrobial which for the treatment of the infections, that can alters the gut flora, and hence an alteration of gut flora by antibiotics may disrupt the enterohepatic cycling of certain drugs. Drugs can alter absorption by gut wall effects, like certain drugs they alters the gastric and intestinal motility and hence the absorption, like anticholinergic drugs, tricyclic antidepressant and others. Now coming to the subcutaneous and the intramuscular route. These are the basically subcutaneous means under the skin, intramuscular means within the muscle. Now here the drug is deposited in the vicinity of the capillaries. So lipid soluble drugs pass readily across the whole surface of the capillary endothelium. But what about the lipid insoluble drugs? They can pass, most of them can pass through the large paracellular space, and even the drug with very high molecular weight, they can pass via the lymphatics. So most of the drugs are absorbed by this route. Absorption from subcutaneous site is slower than that of intramuscular site. Application of heat or the exercise can increase the vascularity of the tissue and hence absorption, while giving vasoconstrictors, certain local anesthetics. Anesthetics mane? Anesthetics mane basically drugs which are used to decrease the pain sensation. So certain local anesthetics, they are combined with the vasoconstrictors, adrenaline, so that the drug can be present at the local site for a longer duration and increase the duration of action. So certain vasoconstrictors, they retard the absorption of the drug systemically, like adrenaline injected with the drug local anesthetic, they are retarding the absorption. Incorporation of hyaluronidase, they facilitate drug absorption from the subcutaneous injection. Many depot preparation, depot mane drugs that are used which can act for a very longer period of time. So many depot preparations like benzathine penicillin, benzathine penicillin we give every 21 days, so much time they are acting. So benzathine penicillin, protamine, zinc, insulin, depot progestins, etc. can be given by these routes, by intramuscular or subcutaneous. Coming to topical sites, it can be skin, cornea and others. Systemic absorption from topical application can occur. For example, we say when the eye drops are used, it can pass through the nasolacrimal duct and can be absorbed by the nasal mucosa. However, only few drugs significantly penetrate intact skin. Kon drug ta intact skin penetrate korte pare? Some examples are given here, like glyceryl trinitrate is an anti-anginal drug, like hyoscine is an anti-spasmodic drug, nicotine, testosterone and estradiol, and these drugs are used. These drugs are used via topical application even for systemic action. So these are the drugs have been used in this manner. Absorption can be promoted, can be enhanced by rubbing the drug in an oleaginous base, oily base, তাহলে অনেকক্ষণ থাকতে পারবে। Organophosphate insecticide, এটা তোমরা অটোনমিক নার্ভাস সিস্টেমে পড়বে। Organophosphate insecticide coming in contact with skin can produce systemic toxicity. তাই জন্য পেশেন্ট যখন অর্গানোফসফেট পয়জনিং নিয়ে আসে, জামাগুলো খুলে দিয়ে শরীরটা ভালো করে পরিষ্কার করতে বলি, যাতে ইনট্যাক্ট স্কিনে অ্যাবজর্পশনটা কম হয়। অ্যাব্রেডেড সারফেস থেকে কিন্তু তাড়াতাড়ি অ্যাবজর্পশন হবে, কেন? বিকজ দ্য ক্যাপিলারিজ আর এক্সপোজড। ফর এক্সাম্পল, ট্যানিক অ্যাসিড অ্যাপ্লাইড ওভার বার্ন্ট স্কিন ক্যান প্রডিউস হেপাটিক নেক্রোসিস ইভেন। Cornea is permeable to the lipid-soluble unionized physostigmine. কিছু বেসিক্যালি কোলিনার্জিক ড্রাগ রয়েছে একই ক্লাসে, ফাইসোস্টিগমিন, নিওস্টিগমিন, দুটোর মধ্যে তফাৎ রয়েছে। দে আর ইউজড ইন বেসিক্যালি মায়াস্থেনিয়া গ্রেভিস। দুটোর মধ্যে তফাৎ রয়েছে, এটা কিন্তু লিপিড সলিউবল আনআয়োনাইজড, আর এটা কিন্তু আয়োনাইজড ফর্ম, লিপিড ইনসলিউবল। So cornea is permeable to physostigmine but not to the neostigmine, although both are of the same class of drug. Drugs applied as eye drops may get absorbed through the nasolacrimal duct, said earlier. Mucous membrane of mouth, rectum, vagina, they absorb lipophilic drugs. Now coming to the bioavailability, it is a very important pharmacokinetic parameter. What do we mean by bioavailability? Is basically defined as the rate and extent of absorption of a drug in unchanged form in the systemic circulation. So it refers to the rate and extent of absorption of a drug from a dosage form. Dosage form ta fixed thakte hobe, from a dosage form as determined by its concentration time curve in blood or by its excretion in urine. How it is measured? It is measured as a fraction of administered drug. For example, we are taking 100 milligram of drug via the oral route, and in the plasma there is only 70 gram that has reached. So the bioavailability of drug is 70% here, right? So it's a measure of the fraction of administered dose of a drug that reaches the systemic circulation in an unchanged form. Bioavailability of drug injected intravenously কি হবে? Intravenous route কি হবে? আমরা ডাইরেক্ট কিন্তু সিস্টেমিক সার্কুলেশন দিচ্ছি, so that will be 100%. Now factors affecting bioavailability. তো oral route bioavailability alter হওয়ার কারণটা দুটো মুখ আসে। তো the bioavailability is differing for the different drugs via the different route other than intravenous because of two reasons. One is they are incompletely absorbed, and number two is before reaching the systemic circulation they undergo some sort of metabolism that is called first pass metabolism. Okay, so the absorbed drug may undergo first pass metabolism in the intestinal wall if taken by orally and in the liver. Okay, so or be excreted in the bile. So these are the two main reasons for the change in bioavailability. Incomplete bioavailability after subcutaneous or intramuscular injection is less common but can occur due to local tissue binding. Now coming to the term bioequivalence, same drug is there but either different manufacturer or the same manufacturer of different batch, the bioavailability may differ. Why? If we take the oral route, for example, I told you earlier that the absorption will depend on the dissolution and disintegration. Now, what happens depending on the particle size? একই compound কিন্তু particle size টা different আছে, so dissolution time will be different. Now একটা drug এর মধ্যে, for example aspirin, take it aspirin, aspirin থাকে না, তার সঙ্গে অন্যান্য constituent থাকে. So there is an active ingredient, there is also excipients. What are the excipients? It can be basically binder, it can be sweetener and other agents. So that can affect the absorption of the drug. Different drug একটাই drug, different manufacturer, the excipients can be different, particle size can be different, the tablet that is compressed, the compression pressure can be different. So different factors are there that can alter the bioavailability of same drug from different manufacturer or in different batches of the same drug. So two preparations of the drug are considered bioequivalent when the rate and the extent of bioavailability of the active drug from them is not significantly different under suitable test condition. যদি different না থাকে, they are called bioequivalent drug. Okay. Difference in bioavailability may arise due to variation in the disintegration and dissolution rate. বোঝা গেছে? Now that is why, for example, a drug has been basically first invented or discovered in the country. Now the same drug, if being manufactured by a different company, then they have to show that the two drugs are bioequivalent. Only then that can be marketed in a country. Okay. The same drug being manufactured by a different company or a different pharmaceutical company, they can only market in the country when the two drugs are bioequivalent. Means the rate and extent of absorption of the two drugs are almost similar. So what is the practical implication of bioequivalence? এই bioequivalence জেনে লাভ কি আছে? In most of the case, this bioequivalence does not have got no clinical significance. Only when the drug has got low margin of safety. Low margin of safety মানে একটু ড্রাগের ডোজটা বাড়ালে কিন্তু টক্সিসিটিটা বাড়বে. Like in case of digoxin. Digoxin is an anti-arrhythmic drug. Like in case of warfarin, theophylline. So drug with low margin of safety or where dosage needs precise control, like anti-diabetic drugs. কতটা ডোজ লাগবে সুগারটাকে কন্ট্রোল রাখার জন্য, in that case কিন্তু bioequivalent drug থাকাটা better. Okay. So drugs with low margin of safety or where dosage needs precise control, in that case কিন্তু bioequivalence is very much important. It may also be responsible for success or failure of an antimicrobial agent. একটা same drug of different manufacturer আমি দিলাম, both are not bioequivalent, then it may even lead to the failure of an antimicrobial regimen. Now coming to the distribution, এটা absorptionটা হলো. Distribution মানে কি? Distribution মানে পিছন থেকে, আচ্ছা, what are the different aspects of pharmacology, pharmacokinetics? দাঁড়া, পিছন থেকে বল, দাঁড়িয়ে যা. Next. হ্যাঁ না, এগুলো খুব কমন জিনিস. এটা প্রথম জানতে হবে রে। নেক্সট elimination. So absorption, distribution, metabolism, elimination. Absorption মানে नेक्स्ट हाँ बोलो कोई दिक्कत नहीं है তোমাকে জিজ্ঞাসা করেছি রে নেক্সট বলো next the movement of the drug from the site of from the route of administration to the systemic circulation. Sit down. Bioavailability mane what do you mean by bioavailability? Bioavailability mane ki ache bol? Acha tell me a name of weakly acidic drug. Tell me a name of weakly acidic drug. হ্যাঁ ক্লাসটা না শুনলে হবে না রে হাসলে তো হবে না ক্লাসটা শুনতে হবে অনেকবার বলা হয়েছে weakly acidic drug. Tell me a name of weakly acidic drug. Aspirin. ঠিক আছে why the weakly why the weakly acidic drug is more ionized in the weakly acidic drug is more ionized in which medium? Acidic or alkaline? Acidic drugs are more ionized in which medium? Acidic or alkalic? Sorry? Alkaline medium. Acha. ठीक है. Coming to the distribution. Distribution means movement of the drug from the systemic circulation to the different tissues. So once a drug has gained access to the blood stream, it gets distributed to other tissues that initially had no drug. ঠিক আছে route of administration থেকে ড্রাগটা সিস্টেমিক সার্কুলেশন অবধি এসছে এখান দিয়ে ডিফারেন্ট টিস্যু থেকে যাবে যেখানে ড্রাগটা এই মুহূর্তে নেই concentration gradient being in the direction of plasma to the tissues. বোঝা গেছে আমি ড্রাগটা নিলাম ওরালি ড্রাগটা প্লাজমাতে গেছে এখন ড্রাগের ডিফারেন্ট টিস্যুতে ডিস্ট্রিবিউট হবে লাইক ইন কেস অফ ব্রেন in case of liver they are not having any drug now so the concentration gradient is plasma to different tissues বোঝা গেছে এটা concentration gradient being in the direction of plasma to tissues movement of the drug from plasma to tissues occurs until an equilibrium is reached after reaching the equilibrium that between the unbound drug in the plasma and the tissue fluid. So equilibrium কার মধ্যে reach হবে between the unbound drug in the plasma and in the tissue fluid. Factors affecting distribution of drug. What are the factors that affect? Again, lipid water partition coefficient of drug, that is higher the lipid soluble drug, more will be distributed. Number 2, pKa value of the drug, that will basically show the ionization of the drug in the different medium. So pKa value of the drug, degree of plasma protein bindings. Many drugs are highly plasma protein bound. Plasma protein কোথায় থাকবে intravascular compartment এ যদি more of the drug is bound to the plasma proteins lesser will be available for distribution. Okay, so degree of plasma protein bindings they also affect the distribution of drug. Affinity for different tissues. Certain tissues are distributed more in certain tissues are more favorably distributed in different tissues like chloroquine. It's an anti-malarial drug. It is more distributed in the liver. Fat lean body mass ratio and diseases like congestive heart failure, uremia and cirrhosis. Now coming the distribution show করার জন্য the important pharmacokinetic parameter রয়েছে is the apparent volume of distribution. What do we mean by apparent volume of distribution? Considering the single compartmental model, different tissues different compartment রয়েছে কিন্তু সেটা দিয়ে কিন্তু আমরা মেজার করতে পারবো না using the same compartmental model এটা ব্লাড আছে এটা কিন্তু হোল বডি সেখানে ড্রাগটা দিলে পুরো বডিতে ডিস্ট্রিবিউট হয়ে গেল 1000 milligram of drug was given and it was seen that the plasma concentration was 50 milligram per liter So, the volume of distribution comes as total drug given by plasma concentration, that shows the apparent volume of distribution. Is the volume that could accommodate all the drug in the body if the concentration throughout was the same in the plasma. Lipid insoluble drugs do not enter the cell, so the volume of distribution will be low. Drugs extensively bound to plasma protein, apparent volume of distribution will be low. Drugs sequestrated in other tissues, the volume of distribution will be low, which will be much higher when the drug is sequestrated in other tissues. So, plasma concentration will become lower, volume of distribution will be higher. In case of poisoning, drug with large volume of distribution, here hemodialysis are ineffective. Pathological states, for example, congestive heart failure, uremia, cirrhosis of liver, they alter the volume of distribution of drug. Redistribution, the drugs which are highly lipid soluble and basically they get initially distributed to organ with high perfusion like brain, like kidney. Later less vascular tissues get the drug. Now what happens if the main site of action of the lipid soluble drug is in the highly perfused organ? When the drug is redistributed to the less vascular organ, then what happens? That there is termination of action of the drug. Like in case of anesthetic drug, general anesthetic, their main Thiopental Sodium, its main action is in the brain. Now initially when the drug is given, the drug is distributed in the brain which is highly vascular, then within a few seconds of time the drug is diffuses back into the lesser vascular organ. So the concentration of the drug in the brain falls and this causes termination of action of the drug although it is present in the body. This is called redistribution. Greater the lipid solubility of drug, faster is redistribution. Anesthetic action of Thiopental Sodium already explained. Penetration into the brain and CSF, we know about the blood-brain barrier due to tight intracellular junction and well superadded by the foot process of astrocyte. There is also blood CSF barrier. So, streptomycin, neostigmine which are lipid insoluble, they cannot pass through the through the blood-brain barrier. Again, there are some efflux transporters in the blood-brain barrier like P-glycoprotein. They limit the exposure of the drug in the brain. Now, both these barriers, that is blood-brain barrier and the blood CSF barrier, they are lipoidal and they limit the entry of non-lipid soluble drugs. Efflux transporters are dopamine and levodopa. Basically, we know in Parkinsonism patient, the concentration of dopamine falls in the brain. Now, when dopamine is given, dopamine cannot access through the blood-brain barrier. So, its precursor levodopa is given that passes through the blood-brain barrier within the brain. It is metabolized to dopamine and dopamine helps in the treatment of Parkinsonism. Inflammation of meninges of brain, they increases the permeability of these barriers. There is also enzymatic blood-brain barrier. Blood-brain barrier is deficient in certain areas already known to us from the physiology class, like in case of chemoreceptor trigger zone. So, most of the drugs are causes nausea. Now, passage across placenta, placental membrane is also lipoidal, allows entry of only lipid soluble drugs. The placental efflux transporters are also there like P-glycoprotein, like BCRP, breast cancer resistance protein, MRP3. Placenta is also a site of drug metabolism.